listening to Boomers Today with your host, Frank Sampson.
Good day. Welcome everyone to Boomers Today. I'm Cynthia Perthews, and I'm filling in today for Frank Sampson. I'm honored to have Miryam Rabner as my guest today. Now, Miryam is the Cultural Sensitivity Liaison and Outreach Coordinator at MJHS Hospice and Palliative Care in New York City. Now, that is a big mouthful. So I'm going to start right off the bat with Miryam. Can you tell me what exactly does the Cultural Sensitivity Liaison and Outreach Coordinator actually mean?
Hi, Cynthia. Thank you for having me and for allowing MJHS to be represented through me. I started as a volunteer 16 years ago, and then I was transitioned into outreach coordinator, meaning that I'm a community liaison. I go to different communities. I tell people about end-of-life options. I help them get in touch with their own wishes, get in touch with the wishes of their families, and see whether they are already entitled to hospice and palliative care, or whether they just want to have information about services that they're eligible for and that are available in case a serious illness hits them or is diagnosed in somebody whom they love and whom they take care of. So that's the outreach coordinator. Cultural sensitivity liaison is that, as you could tell from my accent, I was born in Europe. My mother tongue is German. I came here for college. I'm the child of a Holocaust survivor, and that serves me well in my approach and my encounters with different groups of people who are not fluent in English, people who also have an immigrant story, just like I do, people who have been traumatized or are the children of traumatized groups, because there's an affinity that we have. And so the cultural sensitivity means that I can be a liaison to the healthcare professionals and represent cultural needs, taboos, traditions of the people who are different than the majority of people. And that can include LGBTQ communities, the veteran community, people who speak different languages, and as I said, Holocaust survivors, Jewish Orthodox people, Jewish people who are very tied to the religion, whoever is a little bit in need of a higher touch support.
Is this a position that is common in this space or in common in other hospitals, or is this something that's specific to MJHS?
I believe we were pioneers at MJHS. I know we are pioneers that we even updated our electronic medical charts to include, for example, SOGI, sexual orientation, gender identity. That is just starting to take hold in the healthcare arena. And the fact that I was hired 15 years ago, 16 years ago, actually, specifically to connect with people who may not get the information in a newspaper or in a book, or who don't have access to all the information because there is inequity or there is a fear of going to a doctor or a mistrust. I believe made us pioneers, and we've expanded it. I have a colleague who speaks Mandarin and Cantonese and who is very involved with the Chinese and South Asian community. We have a veteran liaison who just deals with veterans who need extra support, information on benefits, eligibility, certificates that they need to access. And we obviously have somebody who speaks Spanish as well as English and is available to the Latino population. And we intercorrelate, we work together. So we support each other. And if we see, oh, I could use somebody who speaks Spanish because they're going to build a very quick rapport with Spanish speaking people, I'll invite her to an event that I'm hosting, an educational fair or something like that, so that we are reaching as many people as we can.
Okay, so you came to this position. You said you've been in this role, or you've been with MJHS for about 15 years. Is that correct? So what prepared you to be in this position besides your upbringing and your birth? But what other things did you do? Did you study or did you work towards that got you to this place?
This is very interesting because I come from a totally liberal arts background. I'm actually by training a professor of comparative literature. And I came to hospice work because I myself am a cancer survivor. And when I saw a small ad in my synagogue bulletin that a hospice residence was planned to be opened in Riverdale, New York, and they were looking for volunteers, I felt this calling. I could do this. I said, I've smelled death up close. I was gravely ill. I went through all the treatments. I stayed alive because I still had younger children, and I can do this. And so I said, I'll go to the introductory meeting and see what it's about. And I remember I was talking to my dad who lived in Europe, an older gentleman, very highly educated, a medical professional. And he said, why are you doing this? This is so depressing. I don't want you to do this. Haven't you gone through so much already? And I said, I said, Dad, because I've gone through it, I'm not afraid of it. I can hold it for other people. And that's how I started.
You know, it's interesting because a couple of things here. My son has a degree in comparative literature, and I tell him that I was glad he was able to major in that, and he had the freedom to do that. But I said, I'm not sure what you're going to do when you finish. You can be a professor. And so now he's not a professor. He did find some vocation, but it's good to know that he could have done something else as well. And then
it's a luxury.
Yes, correct. And then I come from a different background as well. I come from working on Wall Street, but I spent that time, afterwards, towards the end of that career, working with my parents and understanding and trying, as you said, smell death. I was embracing death and trying to help my parents embrace death because, as I tell my clients, it's not if, it's when. And that we all wish that we would just go to sleep and not wake up. And that, as I also add in, bounce our last check. But that isn't the way life is, and it's not the way it's going to happen. And so, it doesn't mean that to work in these areas that we work in, that we need to have a degree in medicine or we need to have a degree in counseling. We don't have to have that, but we do have to have an empathy and a caring about this population, which we also are moving into ourselves.
Right.
One of the things that, as we talk about this, I love hearing about your journey, and I'm sure that you have like a lot of different stories. One of the things I'd really like to talk about first is, as we talked about our age, is there an age minimum to be involved with these types of programs, or to even put together, as I'd like to talk about, an advanced directive? If you could talk to us a little bit about that.
Yeah, there is no age minimum for advanced directive. When I speak to people, and I've spoken to you about it as well, Cynthia, COVID has taught us that grave illness and sudden illness does not care how old you are. Okay, we also have a pediatric hospice. I know that death or grave illness does not care how old we are. But for the advanced directives, don't wait till you're 80 and don't think it's not going to affect me, because we're all going to die. We were all born and we had nothing to do with that. Most of us lucked out, and here we are. We had productive lives and we're still contributing to society and living full lives, but we don't know when it's going to be over. And so to think about how we want our end of life to be, and to have some measure of control, not full control, because we don't know how it's going to be, but we can try to control some of the things that might happen and prepare for them. And that means having tough conversations with ourselves, really thinking, what do I want? What's important to me? What gave my life meaning? And what do I think will give my death eventually meaning as well? What are my faith values? What are my traditions? What are my family relationships that I need to address? And so the first conversation one has to have is with oneself. And that's a tough one. And it's not a one and done. How many times do I think about it and I say, oh God, how could I even imagine having the grandchildren in bed with me? I don't want the grandchildren in bed with me. I just want quiet. I don't want anybody touching me. And then 2 weeks later, if I go back or I'm shampooing or shaving my legs, and then I think, oh, when it's over, it would be so nice to have the kids near me. Okay. So we have to really go back there, be uncomfortable, be scared. But once we come up with this works for me, and it's our show, it's really our show, for one of the only times where we can be totally selfish and self-centered and say what we really, really want, then we have to share our wishes with our families. And not just document our wishes, we also have to select a person who is going to speak on our behalf, a surrogate, or as we call, as an agent for us. And that's a hard topic to have with someone, and it's a hard selection, but we must go there.
I agree. And my parents, I come from a family that did not have a lot of discussions around death and dying, did not have a lot of discussions around deep subjects. It wasn't what was in our world. But my parents came to me in their 50s and they brought me their advance directive. Now, we didn't discuss it. They just handed it to me, at which point I put it away and my sister put it in the attic. We didn't talk about it because we said, they're too young. What are they doing? I can't believe they've done this. If we fast forward, and my parents then went through their process, and I was so pleased that they had done those documents in an earlier age. And at 50, I did my documents and I took them to my son and I sat with him at dinner and I tried to talk with him about it. And he said, oh, you're being morbid. I don't want to have this discussion. But that was a door opener. And we have these discussions a lot more now because it's not morbid in a sense. And I want my children to understand why I've made these decisions. And I want them to understand, I want to try to normalize death, if you will, because it is, you're right, we're born, we die, it's not by our choice usually. And but we find that families don't do that. Is there a way we can help them do that?
Yes, I think by going after them relentlessly, it sounds very harsh and it sounds unloving. I had the same experience. I said to the kids, I have 2 sons, I need to talk to you about something. And my oldest son kept saying, la, 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 la. And I said, grow up. I want you to sit down. Now is a great moment for me to discuss it because I'm well, I'm healthy, I don't have cancer. I wanted to sit down and hear it because this conspiracy of silence is not going to get us anyplace. And I'm doing you a huge favor. This is a gift of love that I'm giving you, my 2 children and my husband and my sister, by telling you how I want it to play out. And I want to explain to you why I'm choosing certain options, why I don't want to have a tube in me and be artificially breathing, or why I don't want to go, if my kidneys fail, have dialysis every day or 3 times a week, so that we can see the pros and cons and I can explain it to you. And then I want you to be on board and be supportive of each other. Not that the older son says, that's not what mommy would have wanted, when the younger son said, mom said no interventions, so that there's no strife. I said, you're going to be sad, because we're going to say goodbye. And the topic is a sad topic because we're talking about the end of our relationships, the end of my life. But we have to revisit it. And so I would bring it up. They would come for Thanksgiving. And I said, by the way, I want to talk a little bit about more. Mom, where are the pies? I said, we'll have pies. Let's have a glass of wine. I'm creating these alcoholics because I always say, let's open a bottle of wine. It'll take the edge off. But, you know, I have cried with them and I said, it's okay that we cry because eventually we're not going to see each other anymore.
Correct. Well, listen.
But I revisit it, and now when we are, and I say something or I read something in the paper, and I selected my younger son actually to be my healthcare agent. And I said, you know what that means for me? And he goes, Mom, you can wake me up at 3 o'clock in the morning and I know exactly what you want.
Good. That is the way it should be. So we're going to take a quick little break and then we're going to come back. So just stay with me and then we'll return with Miryam Rabner. So today's sponsor is Senior Care Authority, which is a national elder care consulting company specializing in senior living. With over 60 locations around the country, Senior Care Authority's team of certified senior advisors work in person with older adults and their families to find the best care and living options. So if you have questions or need help navigating the maze of senior care and living options, reach out to Senior Care Authority for a free consultation. You can go to www.seniorcareauthority.com to find a local representative and get the help you need. So welcome back, Miryam. One of the things I also wanted to ask you about, and I know we had a brief discussion about this, I have a number of clients, my team touches about 1,500 families a year. And in supporting those families, we have regular conversations around hospice. And it is a conversation that our families don't want to have traditionally. And the words that they use regularly is, she's not that close to death. We're not that close to death. It's not time yet for hospice. And I help them, or try to help them, understand that there's not a time necessarily. I'd love for you to talk about, when is the time to discuss hospice? And also, can you weave in there the difference between hospice and palliative care?
Yeah, the difference between hospice and palliative care, as I will write in an upcoming article, actually, is the following. Both of them, palliative care and hospice, are an interdisciplinary team effort to support somebody and to manage pain and symptoms of a serious and often life-limiting illness. That goes for palliative care and for hospice. Okay, palliative care can come in when you have a bad diagnosis, but it doesn't have to be a terminal diagnosis, and you're still looking for a cure. You're going for treatments, you're going for curative interventions, but the treatments themselves can give you diarrhea, or alternatively can give you constipation or mouth blisters, or they burn if it's a radiation treatment, or any of the symptoms that detract from your quality of life. Then you are entitled to have palliative care support. Now, most hospitals have a palliative care department, even though they don't advertise it. And I should say most urban hospitals, because in some of the rural areas, they don't have it. And it's a consultative service. You could go in, or the palliative care team works with your primary care physician or your specialist. And you have the visit to the palliative care team, or from wherever it meets, and it can be given any place where you reside, gets billed to your insurance company as a consultation. So just like if you went to a cardiologist for a special consultation, gets billed, there may be a copay for it. But palliative care is available to anybody at any stage of an illness, regardless of age, regardless of immediate prognosis. Yes, it's going to be a serious disease, because you're not going to go if you have a rash for palliative care. So it is going to be something that impacts you, and where you're also suffering, not just physically, but emotionally, psychosocially, and spiritually. And the whole team of a clinician, a physician, and a spiritual care advisor, and a social worker will be part of the care group that services you. Once your disease progresses, a doctor might come to you and say, we're not going to get a cure for this. We can't stay on top of it. And you see that some of the side effects from some of the treatments are debilitating you. And we really think that you are declining and your life is ebbing out of you. And we might recommend that you switch over to hospice care now. Hospice care is also palliative care, but it's a much more high touch and specialized care. The same team approach. The only difference is that the patient is no longer looking for a cure. It's rather comfort, it's quality of life, it's peace and quiet, it's time with family and loved ones, but it's no longer trying to so-called beat the disease.
Mhm.
And so hospice comes in, as I said, as a group of people, can be delivered wherever you want, and is covered by most insurance companies, certainly by Medicaid. It's a Medicare entitlement. And anything that's related to the hospice diagnosis will be covered by that insurance. And it also, really, both palliative care and hospice care take into account the family and the circle of caregivers who support you, because they're suffering too. They're looking from a different perspective, but they're also looking at a loss or a decline or a big change in their loved one. So they are part of the team discussions, of the goal of care discussions, and they're being supported, and they're supported once a patient is on hospice for 13 months after the death of a patient who's been on our hospice or any hospice service, which takes them past the big holidays, takes them past the birthday of the departed, takes them past the first anniversary. Those first days are always the toughest ones. And so there are group support meetings, there's individual therapy, and there is support so that you're not just left after the death in this black hole that you can fall into.
Well, I also have clients who have what I say graduated from hospice. So something happened in their disease or in their diagnosis, and things changed, and they stepped out of hospice for one reason or another.
And you know what? It's not a prison sentence if you are on hospice or palliative care. So I started, and we still had a lot of AIDS patients 16 years ago. We have no more AIDS patients. The cocktails were developed. People went off hospice. Some of them are still alive. And we saw it with breast cancer. Once the gene test became much more acceptable and reliable, people said, oh, there's a new drug out there. I want to go off hospice. I have a chance. And if it worked, bravo. We stayed in touch. We applauded. We helped them. We tried to make a safe discharge to make sure that they have a network of support, both clinical as well as for their daily activities, caregiving, food, etc. And God forbid, if the illness returns or it returns in a different form, they can always call and come back.
Correct. And I also think that it provides, so as you mentioned, it provides this support for the families. It provides a support, we see it also as providing support for the caregivers that may not be the family, the paid caregivers who are there with this loved one. And it's an extra set of hands occasionally, an extra set of eyes occasionally, some extra support for that paid caregiver that may not be a family member. They're getting support as well.
Yes, and if a patient / client is in assisted living or in a nursing home facility or a rehab facility, hospice comes in as an added layer of support. It doesn't kick out the caregivers who are hired there. They come in, they collaborate as a team, they share some of the observation, they share some of the duties, but a hospice nurse is going to be much more educated on wound care than a caregiver who works in assisted living. So they come in, sometimes they train them, sometimes they say, this is what you have to look for. This is when you have to call me. I need to come in if this and this happened, so that the patient is always the center of attention, and then the circles around them are family, are professional caregivers, our community, our friends, etc.
Correct. Yes, I agree. It's I just find such joy and peace, and found such peace when my mother was under hospice care for a period of time. And she just carried our family through it. She carried my mother through it. She carried my father. It just was a very, it was meaningful for me, and it gave me a lot of education on it. And I want people to have an education before their loved one is getting ready to pass away. So I could talk with you about hospice forever, because I love hospice and palliative care, and I love what you do, and I'm crazy about you. And so that is why we also are using you to do some articles in our newsletter. And I've gotten a lot of response on that idea. And if you're interested in a newsletter to hear more about Miryam, I can tell you with us, you can go to www.scanyfl.com and you can sign up for a newsletter and you'll see Miryam. She's going to be with us for a few newsletters. But also, Miryam, if they want to get in touch with you, what's a way that people can get in touch with you for help?
People can get in touch with me directly. You're not obligated to come onto hospice. I don't stand by with a clipboard and sign on people. You can email me. It's m.rabner, RABNER, at MJHS.org. You can go to our website, www.mjhs.org, or I'll even give you my cell phone number, 917-721-0754. There are many ways you can contact me. I'll be happy to talk to you.
Great. Miryam, I so appreciate you coming on with us today. And I like I said, I love you and don't work with you enough. But you're my go-to. So
Thank you.
yeah, I really appreciate it.
Thank you for your trust.
You're welcome. You're welcome. So again, thank you for joining us. This is Cynthia Perthews with Boomers Today. And join us next time as we navigate issues that affect the boomer generation. And thanks to Miryam, thanks to all of our other guests that we have had and that we have coming forward.
Listening to Boomers Today with Frank Sampson. To learn more about today's show, visit boomerstodayradio.com and join us next time for another edition of Boomers Today.